Hello, everyone. My name is Jamal Rana. I'm serving presently as the president of California ACC. I'm thrilled to introduce today's session and all the speakers. Our mission in California chapter is to be the catalyst to empower our members, provide transformative cardiovascular care leading to improved heart health for Californians. So our mission is very, very patient-centered. And the topic of today's seminar is related to that, which is from Cabbage to TAVR, history, reasoning, and future plans for CV outcome reporting in California. I'm very thrilled and excited that we have lots of amazing leaders who will be speaking on this and discussing this from California chapter's government relations chair, Dr. Daniela, to Dr. Abrendis, who is past president of California and actually past president of the National ACC. And we have my friends and colleagues from Kaiser Permanente, Dr. Steinle, Dr. Lee, and importantly, we have Dr. Ben Haresh today as well, who is my counterpart and the president of the STS California chapter. So, and then we have a whole set of colleagues from OSHPD, which is now known as Healthcare Access and Information. So without further ado, I would like to introduce Ms. Elizabeth Landsberg. She's the HCAR Director, and Mike Valley, Deputy Director, Information Services Division. So welcome, and let's start.
Thank you so much, Dr. Rana. I'm pleased to be here. Sorry not to be on camera. I think Kris just sent me the invite. And anyway, here we are. So good evening, everyone. Really appreciate you taking the time to engage with us tonight. We know you're all very busy clinicians who deliver critical care to Californians, but we appreciate the ability to be in conversation with you tonight. I'd like to thank the California chapter of the American College of Cardiology, the California chapter of the Society of Thoracic Surgeons and their leadership, and Dr. Ralph Abrendis, who has been a tremendous leader, partner, and the chair of the department's clinical advisory panel for many years. I'm Elizabeth Landsberg, and I was appointed director of the department last December, so I've been at OSHPD, now HCI, for a little under 10 months. I spent 16 years in the nonprofit sector, advocating for healthcare consumers, including more than a decade at the Western Center on Law and Poverty as a policy advocate working with the legislature, including, I would note, on several issues with Tim Madden over the years. I was a deputy director at the Department of Managed Healthcare, which regulates health plans. I oversaw the help center where patients and providers could file complaints against health plans. And I'm so proud to have joined this organization, which is now a department. As was noted, this year's budget and trailer bills recast OSHPD to a department. So we've graduated given our broadening work portfolio. So we are now the Department of Healthcare Access and Information, or HCI. The new department retains all of its existing programs and functions, but again, this was recognition of our growing portfolio, and also the budget made some changes to the way we do our work. We're expanding, aligning, and optimizing our workforce development programs in particular. So we're transitioning the California Healthcare Workforce Policy Commission to a Graduate Medical Education and Training Council, and that will start meeting at the first quarter of 2022. We're integrating the State Office of Rural Health, which was previously with the Department of Healthcare Services, into the Primary Care Office, which has long been housed at OSHPD. And we're maintaining all of the Health Professions Education Foundation programs without the 501c3 structure. This builds on our existing workforce development programs, which are designed to increase the racial and linguistic diversity of the healthcare workforce, increase the clinical workforce in medically underserved areas, and increase the number of Medi-Cal providers. And I think we're seeing throughout the healthcare arena just a real need to build more primary care clinicians, more behavioral health clinicians, really at every level. You may, for example, be familiar with our Stephen M. Thompson Physician Corps loan repayment programs, which serve specialists, physicians, and surgeons. So it's one of many loan repayment and scholarship programs we have. And with all of those programs, awardees have a service obligation to practice in medically underserved communities. The new department will also strengthen and expand our existing data programs, including transforming the current healthcare workforce clearinghouse to a broader research data center, as well as advancing the cardiovascular outcomes reporting program, which is what we're here to talk with you about this evening. The department has a history of supporting informed decisions through public reporting and data transparency, and we are so grateful for the decades-long partnership with the ACC, the STS, and the community of cardiovascular clinicians and surgeons. We're proud of the impact that the California Cabbage reporting program, C-Corps, have made. So thank you again for your continued commitment to this program, and I'll now turn it over to HCAI's Chief Information Officer and Deputy Director of Information Services, Mike Valley, to make some brief remarks.
And thank you, Elizabeth, and good evening all. Apologies for technical difficulties on my part. I'll be very, very brief. Again, Michael Valley, Deputy Director for Information Services for the department, and our division oversees our data and analytics programs. I just also want to take the opportunity to thank the ACC, the STS, and all members of the department's clinical advisory panel, and all of the consultants and members of the community that have advised and continue to advise our department and programs, as well as department staff, including Kris Krashek and Holly Hoig, and the expert researchers on their team who do incredible work behind the scenes. Thank you all for your leadership, and very much looking forward to the discussion this evening. And I'll close with that, and I'll turn over to the next part of our agenda. I think that's comments from leadership, and Dr. Daniele is next up. Thank you again.
Perfect. Thank you. Good evening. I am Dr. Daniele. I am a non-invasive cardiologist, the Chief of Cardiology at UCSF Fresno. I am here representing ACC chapter. I currently hold the chair of Government Relations Committee, and I just want to welcome everyone on our event this evening, and also just wanted to thank all the members. I mean, this is truly an example of a collaborative effort. I mean, we've had a wonderful relationship with OSHPD for the last 20 years plus, and this is really a testament of us working together, partnering with the ACC, OSHPD, currently now known as Department of Healthcare Access and Information, with Dr. Abrendis, and really coming up with an elaborate way of outcomes reporting to benefit our patients here, as well as our physicians. So thank you, everyone, and looking forward to our discussion. I believe next on the list is Dr. Ben-Harash.
Thank you, Dr. Daniele. Good evening, everyone. It is in fact my distinct honor to participate at your statewide California ACC meeting tonight. My name is Payman, and I'm currently the president of the California STS. I'm a cardiac surgeon at UCLA. Some really exciting and highly pertinent issues will be discussed at tonight's meeting. I wanted to briefly share with you some of my thoughts on the evolution of public reporting and its ramifications over the last 2 decades in cardiac surgery. Public reporting in cardiac operations began in New York State in 1991 and is spread soon after to surrounding states. Initially, there were concerns about risk avoidance and poor care. However, 5 years later, California itself began mortality reporting for coronary surgery on a voluntary basis. As you can imagine, many hospitals, especially poor performers, did not participate, creating inaccuracies in risk models at that time. Passage of a California law, SB 80 in 2001, mandated Cabbage reporting and really changed the game. It enhanced reliability of risk models, and both your society and ours were supportive of such reporting, but also lobbied for appropriate review processes to protect individual practitioners. And I think that's very important. About 20 years later, risk-adjusted Cabbage mortality in our state is around 1%, and there's variation that is minimal across the state. More than ever, our patients are being treated with heart teams, including cardiac surgeons, cardiologists, and radiologists. And while surgeons labeled as poor performers are given opportunities to improve, transfer of highly complex cases to expert centers across the state should not be ignored. I look forward to a robust discussion with all of you, and again, appreciate the opportunity to participate. Next up, I believe, is Dr. Abrendis. Please, thank you very much.
Well, thank you very much, and welcome everyone. I actually wear 3 hats for this conference, this webinar. First, I'm a California ACC member, and as Dr. Rana mentioned, actually served as past governor and past president. I also wear the hat as a senior medical officer for the National Cardiovascular Data Registry, but most importantly for tonight's discussion, have served on the clinical advisory panel for CCOR for 19 years, and for the last 9 years have been serving as the chair of the CAP. So next slide, please. So why are we here today? Well, if you were a clinician 100 or 150 years ago, you were just trying to figure out how to take care of your patient without antibiotics or clinical practice guidelines. Now that clinician has to deal with quality, accountability, transparency, and even cost. Next slide, please. In terms of the landscape for promoting quality, we can have internal hospital cath lab quality programs with quality improvement. We can use registries and benchmarking with CQI programs. You can have focused external reviews. You can participate in external quality programs. There's some statewide initiatives in Michigan and Washington, for example. There are health system-wide programs. ACC has accreditation programs. There are payer and purchaser aligned incentives, bundled payments, centers of excellence, payments for quality, and even capitated systems that focus on high value, quality, cost, and improving efficiency. And as Dr. Ben-Arash has talked about already, public reporting. Next slide, please. One of the challenges of public reporting, of course, is it's sort of like fireworks. There's an explosion of activity in many directions. It draws a large crowd. Some think it's beautiful. Some think it's very scary. You can get hurt if it's not used properly. Next slide, please. And then we have the challenge of outside third-party assessors. Are they doing it accurately? Or is this alternative facts or fake news being evaluated by Yelp or Angie's List or Rate MDs or even US News and World Report? Next slide, please. Here's a slide from the STS. This is Dave Shahian's work, looking at showing that if you were a publicly reported center doing bypass surgery, you had lower risk-adjusted CABG mortality rates than if you were not publicly reported. We can discuss many minutes why that might be, but it is some suggestion that public reporting may have some benefit here. Next slide, please. Dave Shahian also is a leader in coming up with composite scores related to Cabbage and assessing quality. And in this slide, you can see the green centers, which report our public reporting centers, have better composite scores representing quality compared to centers that are non-reporting. Next slide, please. There have been a lot of inconsistencies related to public reporting. Here's an article from from Health Affairs that actually looked at 4 what are considered decent national rating systems: US News World Report, Healthgrades, Leapfrog, Consumer Reports, and looked at centers that were both high and low performers and looked at how these different rating groups overlapped. Interestingly, no hospital was rated a high performer in all 4 rating systems. And in fact, only 10% of the 844 hospitals were rated as a high performer in one rating system and in any other rating system. So we have a lot of challenges. Next slide, please. Here's a slide from Dave Shahian looking at data compared to STS reports compared to US News World Reports. And of the 64 of 67 centers that US News Report said were below average, SDS says they were average. Of the 77% of US News World Report programs that were, quote, high performing, STS found them to be average. Of the one-star programs, that is programs that were not doing well in STS, 70% US World Report said they were average. And if you looked at three-star programs from STS, only, if you will, a good portion of those were found to be average. So why is this? Well, it's because they're different data sources, populations, risk adjustment, quality indicators, and outlier criteria have all led to these differences related to public reporting. Next slide, please. So let me turn this over to my colleagues who can give you the history related to cardiovascular outcomes reporting and where we're going. That's you, Holly.
All right. Hi, everyone. My name is Holly Hoig. I'm the manager of our clinical data group and the C-Corp program you've heard about. Dr. Ben-Haresh did a little bit of introduction to the Cabbage outcome reporting program. He mentioned the voluntary program, which started back in the 90s. And we did, it was only reporting on mortality. There were 3 reports issued back in the day when we actually printed and bound reports. He mentioned Senate Bill 680, Figueroa bill, that converted that program to a mandatory program. And it was had some input from the physicians, and it did establish that oversight of the clinical advisory panel. There are representatives from Consumers Union, the California chapter of the American College of Cardiology, and the California Medical Association involved in getting that legislation passed. And their concern was really that there wouldn't be a due process in the physician level reporting, because the mandatory program was going to have the physician level reporting. So a number of pieces went into that statute that took care of that, and it created that clinical advisory panel we graciously or lovingly call the CAP. And Bob Brook from the RAND organization was our first chair, and the surgeon review and appeals process was implemented. So the mandate said that there would be outcome reports that included hospital risk-adjusted mortality annually, surgeon mortality every other year, but the outcomes were not restricted to mortality. It also mandated that hospitals have a 60-day review period of preliminary results, and they could provide written comments. The surgeons had a 30-day review period that they could appeal their results. The statute also allowed for us to audit the data submitted by hospitals, and it was based on a clinical data submitted directly to OSHPD at that time, a subset of the STS data elements. We have some efforts at data quality and that go into place. The data are submitted these days via an upload into an online system with automated edits. It allows, there's 3 stages that allow for corrections and adjustments to the data. And that includes a stage where we've compared the clinical data to that administrative data that's submitted by the hospitals as well, to look for missing cases or miscoded cases. We do implement an annual audit of selected hospitals. It's actually going on right now. And we have successfully implemented the surgeon review and appeal process since the first 2-year report of 2002 and 2003. We have succeeded in putting out those annual reports every year and the surgeon level reports every other year. The reports now include outcomes in addition to mortality at the hospital level for isolated CABG post-op stroke, isolated CABG 30-day readmissions, and a CABG plus valve operative mortality measure. We also include one process measure, and that is the use of the internal mammary artery rates, and we've seen that rate drop dramatically since we added it. We have made the decision to exclude salvage patients from outcomes of hospitals. Dr. Abrendis may mention that later, and from the surgeons in an effort to make sure no one has to think twice about doing surgery on a patient to save their life. The public reports are on our website, and you can go there, hchi.ca.gov, and find them and click on either the hospital or surgeon level results. Since we do have Dr. Balmer on board, I'm going to turn this section over to him to talk about the elective PCI program. Dr. Balmer?
Right, and thank you very much, Holly, and thank you everyone for joining us today. This is a great webinar, I believe. I put up a couple of slides here for specific reasons. One is this, again, shows a little bit of the history starting back at Title 22 of some of the legislation, then the C Corp, then PCI Campus, then the elective PCI program, and now as we're talking about the patient protection program for TAVR and possibly PCI in the first column. The second column gives the years that these Senate and Assembly bills were introduced and then passed. But importantly, the third and fourth columns, the third column shows that for all of this legislation, the California ACC chapter had significant input in each of these legislative issues, either in input to the text of the actual legislation, or actually in some cases, we wrote the actual text out with CHA and some other partners. Tim Madden was involved with this extensively, and a lot of this shows that California ACC didn't just react to this legislation, they actually participated in writing the text of this legislation. And in the fourth column, we see that the California ACC not only wrote some of this text, but participated in each of the programs of the legislation, including significant participation in the advisory panels, as was mentioned by Ralph earlier, consultants for the programs, as well as proposed increase in the advisory program for the current legislation we're talking today. So California ACC has had a significant participation and partnership with the legislators in generating this. Next slide. So one of the programs we talked about was the elective PCI pilot program that Ralph participated in as well with 6 hospitals. And this was one of the first programs nationally to show that there was actually a equally low event rate or safety was preserved in hospitals that were performing PCI, including elective PCI, in hospitals that did not have in-house cardiac surgery. So the so-called campus program or PCIs in hospitals without on-site cardiac surgery showed to be very successful. And in the pilot program, the report showed good results. Next slide. This program was then extended to the elective PCI program following the pilot success. And that was established in 2014 and 15 and went on to, in fact, develop into what is a fairly extensive elective PCI program in hospitals without on-site surgery in California, using requirements and guidelines issued initially by AHA and SCI and the ACC to have restrictions and requirements for these to preserve and protect the safety of patients undergoing PCIs in these hospitals. Next slide. This shows the current elective PCI program in California. And I just wanted to point out that there is a very intensive initial certification. It involves approximately 1,000 pages of data that is reviewed prior to certification, as well as an actual on-site inspection of the hospital, of all their training, of their requirements, their education for that, leading to potential certification. At this time, we can see in the black arrow, the initial inspections have certified 23 hospitals to, in fact, participate as offsite PCI hospitals. There are 5 in the process, leading to a total of 28 hospitals currently in process for the elective PCI program. And I mentioned this because this is almost a third of the PCI hospitals in the state of California. So it is a very large share of that. After the initial certification, step 2 is an annual review that HCI participates in, reviewing the data that comes from the NCDR data set. And we look at outcomes and results on an annual process for it. And the last stage is the recertification, stage 3. Every 3 years, the hospital must resubmit information and data. Especially, we focus on outcomes and results. We also do site inspections and recommendations based on the data that we have. And the bottom squares show what type of data we, in fact, analyze. The first is the HCI data, which includes volume and 3 outcomes that was discussed earlier, including mortality, stroke, and need for emergency cabbage. That for each elective hospital is compared with the rest of the state of California for it. The next gray bar shows that we also look at other data shown from CSIP, and that data is intensely evaluated at that time. If you could go back 1 slide, because we're 1 slide ahead.
Sorry.
You're still advancing. Well, I know.
Sorry, I can't make it back up.
So there you go. So the third is we do look at NCDR data. As Ralph knows, 36 measures and metrics are evaluated there, whereby we compare each of the offsite hospitals with the rest of the US reporting, PCI hospitals reporting into the NCDR data set for analysis there. And the last is we do individual program site reviews of each of these hospitals every 3 years, where we dive deeply into hospital data, CQI minutes, and other issues. And the idea here is to find out any hospitals that are not performing well, to find out a corrective action program for doing that. And by diving deeply into this, we can often recognize what the problem is that leads to corrective action that actually thereby leads to improvement in their performance. So it's a very active program and allows to maintain safety and quality for this program. Next slide. As we said, there are currently 28 hospitals in the process. Some of them are shown on this slide where we look at that data. And the publication of that does include publication on the HCI website, which is shown here for the link. Next slide. So we now have the perspectives of working with HCI and OSHPD and C Corp. And I would like to offer 2 perspectives first off before we go to the next speakers. One is it involves personnel. So the first person I would like to speak about is Ralph Abrendis, who is in fact a promoter of this program and is largely responsible for much of the direction we've had. Ralph is going to serve as the chair of this of the advisory group for this program. And I would say there is no one more qualified to serve as the chair of the HCI OSHPD C Corp program than Ralph Abrendis. He has shown leadership roles in ACC, nationally, internationally, and certainly at the state level. And he has dedicated a lot of his life to improving the quality of care in California. And as the father/founder of NCDR, he's played a big part in all of us doing a better job in cardiology and cardiovascular care. So my perspective is he's absolutely the right person to be leading this program. The next is Kris Krashek, who in fact, as I said, this is perhaps not our first dance at public reporting for PCI. We've been there before. We had a program, as Tim Madden knows, where we went and we got SCI, ACC, and AHA approval for a program. And we got, in fact, through the legislature, we got through 12 committees in the legislature and got 100 votes in the Assembly and the Senate for passing public reporting years ago in this endeavor. We didn't cross the finish line at that point in time, but I want to thank Kris for bringing OSHPD back to the table for this, not only bringing it back to the table to help us cross the line, but also leading in the negotiations and the discussions to get this recent legislation through. So he's done a great part in bringing this legislation to the forefront where we are today. In addition, I want to thank Kris for the fact that he has been very welcome to increases and improvements in the statistical analysis program that we have done. Kris is open to doing more analysis for this, and we have, in fact, he's allowing us to look at exotic ways of statistical analysis in the
Bomber, we're getting behind schedule, so we're going to have to move on.
With that, I relinquish my time to the next speaker, Holly.
Okay, thank you. Dr. Steinle, are you still on board?
I'm muted, but still on board. Now unmuted.
You are unmuted now.
Okay, I'm Tony Steinle. I'm a general cardiologist and work at Kaiser as well. I started with the voluntary program about 25 years ago, I think, and then until the last few years was working with C-Corps. I have to say, if I had to summarize my experience, I would say it's been great to have an experience which confirms one's faith in government, particularly at this moment in time. The reporting program has really had a commitment to getting it right, both at the data collection stage as well as analysis, and they've wanted to be sure that there was a level playing field that all the hospitals and surgeons were reporting on, and that they were getting the results right, accurate, so that it was fair both to providers and to patients. So it's really been a pleasure to be involved. I have been involved in training the data abstractors for the hospitals, as well as training the auditors who audit the abstraction annually, as was mentioned. I was originally brought on to help develop the risk adjustment variables. We were very quickly told by our advisory panel that we should use the STS variables. The STS variables I found a little bit ambiguous, so I remember going out to one of the surgeon's offices where they had 3 people doing the coding. They sat in the same office. I asked them what one of the variables meant, and the first person said, "Oh, it means this." And the second person said, "No, it doesn't, it means this." And the third person said, "No, it means this." These things were open to interpretation. So from the beginning, making sure the quality of the data was uniform was a big emphasis. And the folks at OSHPD were very committed to this. And in terms of people I've worked with, some of them have been some of the smartest people I know, and I can't say anything other than positive things about the work that they've done in public reporting. So thank you very much.
Thank you, Dr. Steinle. Dr. Matchison got called in to perform a PCI and will not be able to join us. So I'm going to turn it over to Dr. Han Lee.
Great. Can you hear me?
Yes.
Great. I'm Han Lee. I'm a cardiac surgeon with Kaiser Permanente in Northern California. When I was invited to join the advisory panel, I was not really sure what impact I was to have, but allow me to share some personal thoughts over the years. And here are 4 items of personal testimonial that impressed me, and I hope will impress you. Number 1, The mission to publicly report risk-adjusted outcomes of cardiac care in the scope of Cabbage and then coronary revascularization to the letter and, more importantly, to the spirit of the edict. I have found that the operational sessions are all on point, efficient, transparent, and in the presence of legal counsel. I was very impressed. Number two, the data acquisition is very robust. There is a rigid auditing process. There is a grueling cyclical vetting and testing of the mathematical predictive modeling by our data scientists. Impressive. Three, after the appeals process are given due process, the public reports have been easily interpretable and trackable on website. Just as the medical technologies are evolving over the years and decades, I'm also impressed that with Kris's help, that the user interface is also evolving. And fourth, I've been impressed with collaboratives with this public reporting, our California public reporting, with other states and regions, and along with the external collaboration, also with the internal California societies to promote the quality outcomes. I have three items I think we should give some more thought, and that is all the things I've mentioned take time in the process, and in the shadow of other industry sectors and their rapid processing of their data to deliverables, our reporting has a timeline that posts results with a significant lag time. Two, that what actually do these reports mean? And actually Ralph alluded to it. The mathematical modeling has been very gracious in this huge bell curve and confidence interval, so that the vast majority are hidden in the middle cluster with only a few surgeons or programs identified to be standard deviation best or worst. So what does that really mean? And then last, the reporting may have been originally intended for the voter, the consumer, the patient. However, in my experience, I can't speak for how much payers scrutinize the reports. I can say, as someone with boots on the ground doing heart surgery, I do find that those who pay most attention to the reports are the hospital programs and the surgeons. And as Dr. Ben-Haresh pointed out, this has ultimately driven up the quality of care in California, driving down the mortality rates in California. Thank you.
Thank you, Dr. Lee. we're a little behind. I'm gonna turn it right back over to Kris Krashek and Tim for the clinical advisory panel discussion.
All right, thank you,
Kris?
Holly. Thank you, Holly. So just to sort of level set, up to this point, we've had the opportunity to hear about the benefits and the importance of public reporting, and certainly some of the challenges with public reporting. We've heard about the history of our cardiovascular reporting programs here at Department of Healthcare Access and Information. And we've had the benefit of hearing from numerous stakeholders, partners, clinical advisors that have worked with our program, and I really do appreciate their perspectives and their kind words about our program and programs and the way that we go about doing the work. What we want to do here now is sort of shift from that past to the present and the future. And a part of that shift is our clinical advisory panel, and they're going to play a significant role in our future in the directions that we're going. So we do want to sort of start with a little bit more information about our clinical advisory panel. Currently, it includes 9 members. There are 3 members each nominated from 3 different organization areas. 3 nominated from California chapter of the American College of Cardiology, 3 from the California Medical Association, and 3 from consumer organizations. And as mentioned numerous times throughout the call, we are currently chaired by Dr. Abrendis. And you can see here the rest of the members from our clinical advisory panel, and cannot express enough our appreciation for their dedication to our programs, their support of our programs, the clinical expertise, the statistical and methodologic expertise that they bring to our meetings and in their recommendations to our program, and also their passion for the work that we do and for the importance of ensuring and delivering quality of care to all Californians. So I do want to thank all of our current members. Next slide, please. So the CAP role per statute, the original statute, was to review and approve the risk adjustment methodology in the models. So we prepare the models, and then we have a meeting every year where we present those models to the CAP. They review the processes that were undertook. They review the models themselves, the fit, and then we go through a process for them to approve those models. There's also an appeal process in place when we do the surgeon level reporting, and the CAP actually serves in the role of reviewing physician statements and making a final determination on any appeals that have not actually been resolved prior to going to that final hearing, public meeting. The CAP also approves new or deletes existing clinical data elements. And we'll make a mention of this a little bit further with the new opportunities before us, but their role in actually making recommendations on additional data collection. And then the CAP advises in the report structure for consumer understanding. I appreciate Dr. Lee's comments about the improvements that we have made recently in increasing the usability and the engagement from a user perspective around the reports and how we release those. Next slide, please. So Dr. Abrendis is going to jump in here and talk a little bit more about some specific areas where CAP has had input into the program. Dr. Abrendis?
Yeah, thanks, Kris. And also, I wanted to acknowledge all the great comments from Bill, Tony, and Han. So just briefly, the CAP has had significant input related to risk adjustments, clearly a very important role for the CAP. And I want to particularly endorse a comment that CCOR and UC Davis, who past contractors, have been very responsive to our counsel related to these risk adjustments. A noteworthy CAP decisions include, as we mentioned, a process measure. There was marked variability in the utilization of internal mammary artery when we started. There were some centers using it less than 30% of the time. As soon as we started publicly reported IMA use, there was a marked decrease in that variation. We led to, as Holly mentioned, excluding salvage patients, even though there was no proof that hospital performance was affected with risk adjustment, including salvage patients. We were concerned that by acknowledging a Good Samaritan approach, that these patients, which have a mortality rate of 50%, that surgeons might be more willing to take them. And at the time, we thought this could save maybe 50 or 60 lives per year in the state. We approved public reporting for a hospital level post-op stroke. We approved public reporting related to 30-day readmission. And we were continually looking for ways to improve California cabbage quality within the Figueroa law confines. Next. Over the last 7 years, our group has gotten together periodically and just discussing directions where we possibly could go with CCOR and the CAP. We discussed concepts of PCI public reporting, looking at 1-year mortality data rather than 30-day, looking at appropriateness for PCI and Cabbage, stress test data, looking at appropriatenesses and degree of ischemia, looking at isolated valves, something that we weren't allowed to do in the Figueroa bill. Discuss, of course, use of TAVR, percutaneous valves, taking on some of Dave Shahian's composite CV surgery measures, looking into price transparency, and even recently discussing social determinants of health. Next slide. Well, this slide is a particular, sets up the remainder of this discussion. This looks at California volume of cardiovascular procedures and interventions over the last 20 years. And the top line in brown is PCI. The second line in green is, as you can see, is isolated Cabbage. Most markedly is that when we started, the isolated Cabbage was about 29,000 for the state per year. It's now in the 13,000 range. In other words, isolated Cabbage has decreased more than 50%. In fact, Bob Brook, before he stepped down his chair, said, why don't we just declare victory and move on? Next slide, please. This slide, it blows up on the bottom that what we saw on the last slide, looking at California volume of valve procedures over the last 20 years. And you can see in red, starting in 2011, when the FDA led to approving and for use based on safety and efficacy, the use of TAVR in our population in the United States, you can see the marked increase in the use of TAVR in California, so that by 2019, over 7,000 cases being done, markedly higher, if you will, than isolated SAVRs. So this really has led to, again, some of our discussions of where we should go next for the state. Next slide, please. And you're back on.
All right, thank you, Dr. Abrendis. So again, with the blue sky discussions, as it's come to refer to with our clinical advisory panel, and interests that were expressed to us from stakeholders, including from the clinical care community, to bring flexibility to our programs to consider other interventional cardiovascular procedures. It really was identifying the opportunity to bring those interests forward. And with Governor Newsom's proposed budget, this past fiscal year budget proposal, there became that opportunity. So trailer bill language was proposed as a part of that budget bill to recast OSHPD, which we are now, as we've talked about, HCI, Department of Healthcare Access and Information, that would improve and enhance current programs and create new opportunities to meet the needs of the changing healthcare environment, but also with there an opportunity to impose enhancements to existing statutory language, particularly for Cabbage outcomes reporting. So it was based on those previous CAP discussions and stakeholder expressed interests too, at that time, OSHPD, for us to put forth language that would allow this flexibility into our cardiovascular reporting. It also created the opportunity to collaborate and move forward with the California ACC to actually refine that language. And then through that process of collaborating and working with the California ACC to have joint discussions that resulted in a recognized collection of shared principles and expanding of the CAP to ensure appropriate expertise. And some of those principles were, for example, that we did want to focus on interventional cardiovascular procedures. We didn't want to try and do everything all at once. We really wanted to focus on a singular procedure and then make sure that there was time built in to the statute to focus on success within that procedure. So as the process moved forward, the legislation actually moved to include that it would be one procedure every 3 years, and that the CAP would have additional members that would be placed into the CAP if needed to have proper expertise for any new procedure that was recommended and that did move forward. I'm going to pause here, Tim.
Thank you, Kris. And before I jump into my points, I just want to introduce myself. I'm Tim Madden, and I am the lobbyist for the California chapter of ACC. And I was actively involved in working with Kris and folks on his team as the trailer bill language that he was speaking to moved forward. And I just want to make the comment, I know there were some concerns within the chapter when the initial trailer bill language came out earlier in the year. But as we engaged with Kris and also with Dr. Abrendis, who provided a nice bridge to Kris and his team, we were really able to form that collaboration, which really is the premise of the relationship between the cardiology community and what's now HCI. And I just really want to emphasize that they were open to listening to our concerns. Kris mentioned some of the changes that came as a result of those discussions, and I really believe we have a finished product that's going to really be great for folks who are engaging in the expansion of the outcome reporting. So I'll stop right there and not get us too off track, but more than happy to make myself available when we get into the Q&A section.
Thank you, Tim. So going to highlight some of the key opportunities that were included as a part of the legislation is that HCI has the authority to acquire additional data from hospitals or from registries that they submit data to, such as the STS ACC TVT registry for TAVR. And this was important, again, as a part of the process of how we work together, how we collaborate, what are going to be items of importance as we think about implementation of this. One of those was reducing data burden or not introducing data burden. And the opportunity to draw data from a registry where those hospitals that are, for example, doing TAVR are already required to submit data allows us to, again, get the data without additional burden or minimal burden back onto the hospitals. The legislation also adds flexibility in administering the program in collaboration with the CAP. That we can publish a risk-adjusted performance report for an additional interventional cardiovascular procedure such as TAVR, and then also flexibility on the level of reporting, that we can report at the hospital, provider group, or the individual physician level. Again, this being done in collaboration with the clinical advisory panel. It provides the clinical advisory panel flexibility to include other health-related topics in their scope. So down the road, if there's an interest in bringing in clinical expertise that can advise our program in other conditions or procedures, for example, diabetes or cancer, that we would have the flexibility to do so. And then also, again, particular to what we're talking about here, expand the membership of CAP to ensure that the members have the expertise for any new recommended procedure. So again, using TAVR as an example, if that were to be the procedure that we were to move forward with, we would take a look at the CAP, we would look at the expertise within the current CAP membership, and if necessary to have the necessary expertise, we could go ahead then and have nominations for new members to be appointed by the Director of the Department of Healthcare Access and Information. And those nominations would come from the California ACC. Next slide, please. So the next step actually is our forthcoming clinical advisory panel meeting that has been scheduled for November 4th. It is a public meeting. It is open to all. We actually, at the bottom of the slide, have provided the web address to where you can go and receive information for joining the meeting. But at that meeting on November 4th, we are going to be working, we're going to present to the clinical advisory panel the new statutory changes. We're going to discuss possible options for additional risk-adjusted cardiovascular performance measures. We're going to share a timeline and a budget that would be needed, again, beginning with TAVR and what would a typical timeline or budget look like for considering TAVR. And then CAP recommendation on next steps. We're also going to be looking at the expertise of the current CAP, and then if necessary, determine the need for additional members. Just to give an idea of some of the content that's going to be presented at that CAP meeting, Dr. Abrendis is going to go ahead and present now a couple of slides that we anticipate being a part of that agenda.
Thanks, Kris. I'm just going to do one slide. I want to give people a chance to have some questions for the group. Many may not know that we have a public reporting voluntary program with TAVR now nationally through the TVT registry. The TVT registry, as you know, Medicare requires participation for reimbursement. The registry is now starting a voluntary publicly reported efforts, and our first report is scheduled actually for this month. It covers a 3-year period, 2017 to 2020. Again, sites do this voluntarily. They opt in. They receive their star rating and metrics prior to public disclosure. The important part that I wanted to mention, we now have about 750 TVT sites. Only 330 are eligible, that is, had enough data or patients for a 3-year period to fit the criteria for public reporting. And out of those 330, 182 have decided to voluntarily publicly report. And maybe with that, Holly, we could open this up for questions or concerns.
Sure, Kris or Tim can answer questions. So do we open this up via the chat or?
Yes, folks can enter questions into the chat, or I believe I'll defer to Liana, but I believe that they can also unmute and ask the question verbally. But Holly, we do actually have a question already submitted in chat, I believe. I just have to bring it back up. I saw it earlier.
Yes, we have one in Q&A.
And it actually looks like a couple of answers may have already been given by Dr. Lee and Dr. Abrendis, or they're in the process of submitting an answer.
I don't think we can differentiate between whether it's a REMA or a LEMA, but we are able to, and we don't code for that, but we are able to assess whether a LEMA has been done.
Correct. We do have that data, or at least we have in the past. I think it might have changed, but we only report out on either. Any other?
Yes.
Looks like there was a question that came in through the chat from Dr. Shemin, and he asked, what is the role of California STS? He says you only mentioned CAACC.
Okay, Holly, do you want me to go ahead and take that one?
Yeah, go ahead.
Okay, so we're very fortunate that, you know, again, and hi, Dr. Shemin. Dr. Shemin, a member of our clinical advisory panel. Thank you for the question. Again, in the clinical advisory panel, the nominations are specifically from the California ACC, but we are fortunate that we do have surgeons that are represented on the clinical advisory panel that, again, are also you know, members of the California STS. But we're also involved in working with California STS at, again, sort of the data coordinator, data manager, data quality level, but then also via discussions and collaborations that we've had with Dr. Ben-Haresh. You know, again, looking at data, looking at how data is being utilized, and, you know, where are the areas of opportunity as we thought about this program for us to move forward in a manner that, you know, I guess is parallel to other things that may be explored or being explored for consideration by the California STS. So I think right now, you know, the best description is that similarly collaborative process, working, you know, with the different organizations, understanding, you know, what their areas of focus, what their plans are, what are opportunities, and hopefully, again, growing, you know, this into more of a community that is collaboratively working together to get, you know, all the great work that is being done out there, and again, into the hands of those that can utilize it to continue to improve quality of care.
I know we're at time, but there is one more question here. Is the group publicly reporting PCI individual physician data currently? So that might be, I'm not sure what the reference is to publicly reporting PCI data.
Well, we only report hospital level data, Holly. We do not report physician level data in our PCI elective program.
Oh, right. I didn't know if that was the elective PCI or a national level. So, right. We do not do any, the Cabbage has been the only procedure or intervention that we've reported at the surgeon or physician level. Somebody wants to say hello to Dr. Abrendis and Lee.
Right back at you.
Holly, we do have a question that I scrolled up and I saw if there's plans to expand the scope of the program to outpatient centers, and yeah, again in the future outpatient PCI. Again, currently, you know, our focus is on our current portfolio programs, and then working with the clinical advisory panel on, you know, what will be that next interventional procedure that we're going to focus on for the next 3 years. You know, again, we want to make sure that we give ourselves the opportunity to work with our different stakeholders, with the clinical, you know, community, to advise and receive recommendations, develop the methods that you know, focus on quality of the reporting that we're doing, and not necessarily expanding out too quickly into the quantity of reporting that we do. There, I know, is interest in outpatient care and in PCI settings. Right now, with some of the administrative data that HCI receives, we do not receive all of the outpatient data. So we would have to consider, again, you know, other sources of data in order to go ahead and consider additional reporting on PCI in an outpatient setting.
Okay, we are
Am
about
I
5
unmuted,
minutes.
Holly?
I'm sorry.
It's Dr.
Yes,
Freeman.
you certainly are.
So I'd just like to take a few seconds to
Hi, Dr. Sheeman.
thank everyone who's participated in this program. This public reporting in California, since I had the experience in Massachusetts, which now no longer reports. You know, I think we've done a phenomenal job along with New York State. But a lot of the historical direction came from California ACC. It's the way the statute is who was told would appoint members of clinicians to the CAP committee. But I think cardiovascular procedures and medicine are a blend now between surgery and interventional cardiology. You know, TAVR is done jointly. You know, new mitral valve technologies are often done jointly. New percutaneous valve technologies that are on the threshold of coming to fruition will be done jointly. So I think that the partnership of the STS and the ACC should not be like we collaborate, but we ought to be working together equally in helping to chart quality initiatives and who serves on these panels and who has the oversight, you know, going forward. So I make that plea number one. And, but I compliment everyone. And I think, you know, now that there's funding and a separate department and we're not so bound by historical statutory regulation that we're always trying to work within and work around, you know, we've got great opportunities going forward.
Thank you, Dr. Sheeman.
Ralph, do you agree with this? Or,
Well, I do agree, and I think we've had a good partnership over the years. I think historically, I can't remember exactly what actually occurred when the Figueroa bill was passed. Why?
2001.
Well, no, I know when, but why the surgeons were actively involved in that process at that time.
yeah, I think it was kind of like, who's the fox who's going to watch the chicken coop? And I guess they preferred not to have the surgeons measure and watch themselves, and felt that the cardiologists, since Cabbage was the only interventional procedure done for one of the most common operations that was being done in the United States. But, you know, we've evolved so far. This is long before PCI came on board. And I would hope that over time that the cardiology community will also embrace individual reporting, as surgeons have learned that, you know, yes, there's our hospitals, but we have to be transparent about ourselves as individual practitioners also.
We are over time a bit. Any last comments? Kris, Tim, Dr. Abrendis?
I just want to thank all of the panelists that joined in tonight and participating in giving the history and the opportunities before us and the work that we've done together. I also want to thank all of the folks that attended tonight's webinar. Thank you for your interest in the program and the opportunities. And I want to thank those that are going to view the recording in the future. I know we have recorded the session, and we're hoping that there is going to continue to be interest in the work that we've been doing and the work that's before us. And so I just thank you all, and I look forward to working with you all as we move forward together. Thanks.
Thank you.
Thanks, everyone.
Bye, everybody.